Zoom of late, there you go. Zoom of late has been a little problematic or slow. I guess not problematic, it's not the right word, but slow when people join. So, well, good to have you here. Welcome to this very exciting webinar. And I'm just going to do a quick introduction. I'm Gary Harbison. I'm the Executive Director of the Missouri Coalition for Oral Health, a 501c3 nonprofit agency dedicated to improving the oral health of Missourians. We're really best described as a statewide network of oral health advocates. And we have collectively achieved a lot over the past several years, including significant changes to increase access to care and oral health equity. In 2016, we achieved reinstatement of the adult dental benefit in Missouri Medicaid. And in 2022, we actually got the provider rate to go up for Medicaid dental. Really, really big deal. It's now at commercial levels. There's still a little jittery problem around the edges with things not being processed and that sort of stuff, but it's coming online. So we're very happy about that. And we are working now to try to assist providers in signing up for Medicaid, because the new rates are great, but if we don't get people, more providers to get used to working with Medicaid, and most private practitioners have little experience with it, we're going to have a hard time increasing access. So we're working on that. And some of the other areas that we focus on and have done a lot of work in are teledentistry, access to care for people with intellectual and developmental disabilities, community water fluoridation, and keeping oral health a priority in the Missouri legislature. We, in fact, have a couple of pieces of legislation that we're supporting this year. And if you want to hear more about that, try to come to our conference. And since I have the belief that there are many students on here, I'll just remind you, students can attend our conference for free. It's next week, Thursday and Friday, in Jefferson City, Missouri. I do not want to forget to mention that this webinar is in fact sponsored by the Missouri Department of Health and Senior Services Office of Dental Health. So we very much appreciate their sponsorship and their interest in this important area. With that, I'm going to hand it over to Ashley Herman with the Coalition, and she'll do our introductions.
Thank you, Gary. Before I do introductions, I did want to remind everyone today's webinar is being recorded and will be available on our website at a later date. And you will receive a link after the webinar for your CE certification survey. So we have two wonderful speakers today for taking the world by storm innovation in dental sealant application. First is Jill Pyle. She is employed at Missouri Southern State University as the Dental Hygiene Program Director. She has been a dental hygienist for 23 years and currently holds her Associates of Dental Hygiene, her Bachelor's of Science in Biology, and Master's of Education Curriculum and Instruction, all from Missouri Southern State University. Ms. Pyle teaches community dental health education and practicum and oversees 2 teledentistry grants through the Department of Health and Senior Services. Our second speaker today is Dr. Latasha Vick. Dr. Vick is the Director of Community-Based Outreach and Education at Kansas City University. She has a heart for education and looks forward to advancing both education and oral health within our communities. Ladies, I will turn it over to you.
All right, thank you. Can you hear us well, Ashley?
Yes, it's coming through great.
Okay, thank you. So as Ashley said, I've been the director here at Missouri Southern. I started as the director last May, so I've been here almost a year. So I look forward to talking to you today about our new innovation in dental sealant application. So thank you for having me, Dr. Vick.
Yes, and I appreciate the opportunity as well to join Mrs. Pyle on this webinar.
Okay, so let's get started. So there's 3 basic learning objectives that we hope that you get out of this presentation today. First, we hope that you're able to describe current clinical practice guidelines for pit and fissure sealants. And then that you're able to apply the American Dental Association carries classification system to define when sealants are and are not indicated. And then lastly, we hope that you're able to assess first and second molars in need of sealant in the outreach setting using our teledentistry and describe how that process occurs. So first, we want to look at teledentistry. What is teledentistry? So teledentistry really serves, just as you can see, as a means for patients to get oral health when the patient is number one in a remote location, or two, where there is a healthcare shortage, or three, they have lack of access to transportation services to those overseeing the delivery of those services. And so that is basically what teledentistry defines as. So we had gotten a teledentistry Sealant grant here at Missouri Southern, and I wanted to give you a little bit of the purpose of that grant. And then also just talk to you about the history of our grant. So the purpose of the grant was to promote and provide education and outreach for the importance of dental sealants and services in Jasper County via teledentistry to kids that are at high risk. I had somebody ask if I could be louder. Can you hear me well?
I can hear you well on my end, Jill, but if you might be able to just speak up just a touch.
Okay, thank you.
I can hear you fine as well, but there's a little bit of echoey, I guess, or room. It's not bad on my end, but it may be causing a few people.
Okay, I'll try to talk up a little bit louder and see if that can help, okay? So we were collecting data for integration into a basically electronic medical report for the state. And with the grant, we were to provide dental sealant education to a minimum of 220 parents or caregivers, and then we were to provide teledentistry dental sealants to a minimum of 125 children with our grant. So you can see we obtained Missouri Southern obtained the grant from the Missouri Department of Health and Senior Services in 2020, and it was to run through 2022. At that time, DHSS provided us with $66,592.63 for the purchase of equipment and supplies. So we also got that contract extended to go to August of 2023, and they provided us an additional $24,000. We are in hopes that our study and our research and our grant has gone really well, and we're in hopes that we're going to be able to extend that also into 2024. In 2022-21, we purchased 3 mobile units. This equipment included, chairs, light stools, intraoral cameras, supplies. But in 2022, we were able to buy an additional 3 mobile units. So we now operate basically with 6 total mobile units. So when we started our Sealant grant, we started participating in 3 schools. These schools are Wildwood Elementary in Sarcoxie, Missouri, Jasper Elementary in Jasper, Missouri, and Avila Elementary in Avila, Missouri. Those communities are rural communities that are approximately 30 miles, give or take, from Joplin, Missouri. So these areas have a higher need due to the caries rate and limited access to dental care. And then we also saw a higher uninsured population in these communities. In 2020 to 2021, you could see, just for example, in Wildwood Elementary in Sarcoxy, we were able to do 22 sealants on 3rd graders at that school. The sealants were actually screened on the first visit, and then we went back and placed on a second visit at the school. So in 2022, we were able to go in and actually perform screenings and sealants completed on the same day. So you can see we did, for example, at Wildwood, again, we did 209 sealants on grades K through 6, all on the same day. So you can see we were able to increase our sealant placement by approximately 10 times of that. And with us being able to screen and place the sealants on more children, we were able to do that by using a protocol that we're going to be outlining in this webinar. So we want to look at just dental sealants in general. So, sealants we know can protect against 80% of cavities for 2 years. And then research shows that it can continue to protect against 50% of cavities for up to 4 years. And so then also data from the Center of Disease Control Prevention states that children ages 6 to 11 years without sealants have almost 3 times more first molar cavities than children with sealants. So by placing sealants using the teledentistry grant, we were able to protect the children's teeth who do not have access to care. So some more data, less than half of children aged 6 to 11 years have dental sealants. And children from low income families are 15% less likely to get sealant. And so they're twice as likely to have untreated caries. And so those untreated caries or cavities can cause pain, infection, problems eating, speaking, and learning. So we want to note that that's what we were seeing in these rural communities. Actually, less than half of the children had been to the dentist ever. And then less than half of them had had sealants in their mouths. So this intervention or grant was good in terms of being able to go in and help with preventing pain, infection, and having those children having access to more care. So I found this information really astonishing. If you look, so each tooth sealed saves more than $11 in dental treatment costs. And so then if applying sealants in schools and this avenue to nearly 7 million low-income children who do not have them, we could prevent more than 3 million cavities and save up to $300 million in dental treatment costs, which is just, that's a lot. Okay, I'm going to turn it over to Dr. Vick now to discuss some of the clinical practice guidelines set forth from the ADA.
Thank you.
Yes.
So in reference to the first 2 objectives, I will discuss the recommendations for Pitt and Fisher sealants and screening for teeth that are candidates for sealants. So a guideline panel consisting of the American Dental Association, Council on Scientific Affairs, and the American Academy of Pediatric Dentistry conducted a systematic review, and they formulated recommendations to address clinical questions in relation to the effectiveness of sealants to prevent dental caries. And in summary, there are 3 main recommendations, if you will. The first being, sealants are effective in preventing and arresting Pitt and Fisher occlusal caries lesions. The second being, sealants can minimize the progression of non-cavitated occlusal, also referred to as initial caries lesions. And finally, there does not appear to be an advantage of one type of sealant material over the other, which is a revision from their 2008 guideline, which suggested preference to resin-based sealants. So now there's this current recommendation is that there is not a preference in terms of the type of sealant material. So this chart illustrates examples of teeth with sound tooth structure and those with Pitt and Fisher caries. Recognizing evidence supports sealing permanent molars with sound tooth structure, as well as those with initial caries lesions. The participants in this program use visual and tactile methods along with fluorescence to screen for teeth that would benefit from sealants. And again, our focus was the sound, those with sound tooth structure and initial caries lesions. Of course, the permanent molars with sound tooth structure are the ones with no clinical or clinically detectable lesion. And the initial caries lesions in the mildest forms are only visible with drying, while those that are a little further along but not cavitated may be visible without drying. Again, visual and tactile methods along with fluorescence were used to screen permanent first and second molars. In doing this, the teeth are cleaned, dried, and visually inspected. Recognizing discolored pits and fissures can appear to be caries, we use fluorescence as part of this process. This image on the lower right demonstrates how a tooth can have discolored fissures while the lesion is confined to the enamel. And in this case, this tooth on the lower right, being that the lesion is confined to an enamel, it is an initial caries lesion and it is a candidate for sealant. And when Mrs. Pyle goes through the process in armamentarium, we may notice an explorers on the list. In line with Summit's fundamental operative dentistry text, the explorer was used to gently fill margins and defects to confirm and assess cavitation when warranted. Otherwise, visual inspection, intraoral images, and fluorescence was used to identify teeth with sound tooth structure and teeth with initial caries or non-cavitated lesions. At this point, we are aware of the benefits. We've discussed the benefits of Pitt and Fisher sealants, their indications, and as well as which teeth should be sealed, with it being sound tooth structure and initial caries lesion. Mrs. Pyle will now discuss the sealant material used in this initiative as well as the process.
So I want to note that with our grant that we use glass ionomer sealant material. There's many benefits from using glass ionomer sealant benefits. Those are that it's one, hydrophilic. So it can be placed on a moist surface. It can also be placed on partially erected molars. So you can see the advantage of using this with especially like slow erupting mandibular molars, where you might have food that gets trapped under that operculum and it can cause decay prior to full eruption. So a complete isolation is not a concern here, so it can be placed in an area with a moist surface. Another benefit would be that it is fluoride releasing. So glass ionomer sealants release fluoride, so that results in caries prevention and it's not retention dependent. So resin sealants retention is associated with risk of developing caries. Even when sealant is not retained, there is still small particles that are still present in the pits and fissures that release fluoride. So you can see after 28 days, enamel adjacent to glass ionomer contains about 1,181.03 parts per million more fluoride than enamel adjacent to fluoride containing resin. So the release of the fluoride is beneficial to these patients. It also creates a chemical bond, which are superior to the resin because they're not prone to detach or have the marginal breakdown. The glass ionomer sealants will chemically bond to the enamel via like an ionic cross-linking between the material and the tube surface. The resin sealants during breakdown can have like leaky margins and develop caries underneath. Another benefit is that it is biocompatible and antimicrobial. So it's the most like tooth material we have. It has no resin or bisphenol A BPAs. It's also antimicrobial and inhibits biofilm attachment. It also prevents damage from acid and bacteria on the surface by creating an inhibition zone. But the number one reason why glass ionomer is good, it's better in a community health and school setting. This is what we were looking at mostly with the grant. So it's lower technique sensitive. So you don't necessarily have to have an assistant present due to the fact that it can still be a moist surface. You need less equipment and products needed, and which would lead to less overhead. And then it's less time consuming, and you can use it with patients that have poor patient cooperation. It's just good in those areas since it can get moist. It's much quicker. So I want to go over just our setup. We have the glass ionomer sealant material, the capsule, and the conditioner. We had an Explorer and a mirror. We used micro wells or dappen dishes with micro brushes. We had cotton rolls and a triturator to mix the material. So before we started, we would send out a permission slip to the schools. We had to have a signed consent on record. We worked with the nurses in these schools where we could also provide a parent or guardian with a report after the screening. So after we had a confirmed signed consent on record, we were able to complete the screening. You can see the form here that we use at the school to collect the data to report back to the state. We were able to provide a screening with a recommendation to the parent after we were completed with whether, a patient would need to see the dentist as soon as possible. We would also notify them that they would need to see a dentist for a more complete examination. We could discuss brushing and flossing when that needed improvement. Or we could also simply state that we saw no obvious concern and that they just needed to continue on for regular exams. As you can see on the report or the data collection report, we would have the name, the school, age, date of service, grade. We'll go over this area here later, but basically you can determine if they have no dental insurance or a private dental insurance, or if they do receive Medicaid. With our screening, we would go in and note any sealants that were present, untreated and treated decay. You can see here the referral section. We would put the number of filled first molars, second molars, number of sealants done that day. There is an area we would place fluoride varnish when indicated when we were completed with the screening and the sealant placement. And then we did not do prophies, but there is with access to doing prophies in the future. And then we have an area here where we could determine if we had been in the school, where we would go back and see if those sealants were retained to provide that data for the state. So basically, this is showing you the teledentistry sealant flow chart protocol that Dr. Vick and I came up with. So as she noted, we're really wanting to go in and determine first if we have a sound tooth surface or if we have initial caries lesion. If it was a sound tooth, then obviously we would go ahead and proceed and place the tooth with a sealant. If we determined that it had initial caries lesion, we would determine if there was cavitation. Obviously, if there was cavitation, we wouldn't seal. But you can see here, if there was not cavitation, We would then take a diagnostic reading. And then if the diagnostic reading was, we would determine if it was 20 or less. If it was no, then we would not seal. If it was 20 or less, we would take an intraoral photo and then send it back to Dr. Vick via teledentistry for review, and then she would recommend whether we would seal it or not seal it. So you can see initially, basically, we are going to put a sealant on any tooth that is determined that it is sound, or if it has an initial caries lesion, then we would follow up with the next protocol. Basically, what you want to know is their cavitation. So we were initially broad in questioning whether or not a tooth was cavitated for the purpose of this process. Of course, teeth with gross decay or cavitation were not sealed. And these children were then referred on for early dental care. While those experienced discomfort were referred for urgent dental care. The school nurse was involved throughout that process and would notify the parents or caregivers if that was necessary. As far as teeth that had a lesion visible without drying or appeared demineralized, additional steps were taken prior to sealing to determine whether or not the cavitation was present. So we used the Diagnodent. Clinical research has supports the value of using the Diagnodent as an aid in evaluation of caries. A Diagnodent is used to monitor the progression of the caries or aid in the decision to prevent, remineralize, or restore. We used a smaller laser system that produces a wavelength of 655 nanometers, which produces a red light. You can see the intensity of the caries fluorescence is correlated with the intensity of the bacterial contamination or the lesion depth. So you can see, obviously, with readings of 21 and higher, that usually histologically is dental caries. And so those teeth would not be sealed. Then the 0 to 14 is saying that there's no caries present, or histological enamel caries, and it's limited to just the outer half of the enamel thickness. It was this 15 to 20 area where we were concerned that it might extend beyond the outer half, but it's still confined to the enamel. If that is what we found, we would take an intraoral image and take the Diagnodent rating, and we would send that to the supervising dentist by way of teledentistry for review. And then the supervising dentist would determine whether or not to place the sealant on the tooth. So this basically just shows you the process of placing a glass ionomer sealant. We would brush or pumice the tooth. In our in the school setting, we would just basically take a dry toothbrush and brush out the occlusal surface, rinse it very well. Then we would dispense 1 drop of the cavity conditioner into a dappen dish and use a micro brush to place that around. You don't need an assistant to place that. And you don't have to worry about completely isolating or keeping the area dry. We would use a slow speed evacuator section to get the excess saliva out. We would dry the tooth just by blotting it or gently blowing air with an air syringe. But you can see there the tooth surface should still appear moist or kind of glistening. We would tap the capsule on the hard surface to loosen the powder, activate the capsule by pushing the plunger in until it is flushed and hold it for 2 seconds. Then we immediately set it into a triturator, and we would mix it for 10 seconds. Immediately remove the mixed capsule from the mixer and load it into the capsule applier. And make 2 clicks to prime the capsule. And then we would apply the glass ionomer onto the tube. The students could adapt the material, the tube with either a finger or a microbrush and manipulate it into all the pits and fissures. The working time is about at 1 minute, 40 seconds. Obviously, at higher temperatures, the working time is less, but we did find that we had about 1.5 minutes to 1 minute, 40 seconds to work the material. It's self-curing. You can use a light cure to help speed enough, hasten the setting, but we did not use the light cure in our system. It takes just 2 minutes and 30 seconds to be completely cured. And then we recommended a soft diet at following the sealant placement for up to 48 hours. There were students that, did not qualify for sealants due to caries or the parent did not have consent. We were able to go into the school and do the PSP program with the state where we would place fluoride varnish on those children. And then we also were able to do dental education with those students as well, with brushing and flossing to them. We are in the when we were talking about Medicaid, Missouri Southern is in the process of getting approved. We've already been approved for Medicaid, but we're in the process of getting approved for managed care plans. Where this is important is this is what can make these programs sustainable in schools. So that whenever our grant is completed, we're able to go in and file Medicaid to make the reimbursement so that we can keep this program sustainable. We're going to continue doing the work in the rural areas where dental education and care is needed most. But we're looking at being able to do billable services so that we can have the opportunity to maintain doing these screenings and sealant placement, fluoride varnish placement, and maybe hopefully move forward and be able to do prophies by teledentistry in these rural communities. So that basically concludes our discussion on the sealants. We can open it up to questions or comments or discussions.
We haven't had any questions come in yet, ladies, but the Q&A and the chat box is both open and available for questions. If you have a question that you want to ask live, you can raise your hand and I will unmute you.
I also have all of my second year students. They should be on this webinar as well. And so it's kind of interesting. They're the students that we've actually been utilizing the grant and going out into the rural communities and placing sealants. So I don't know if they have if you have any questions for them that they might be able to answer as well.
That's great that we have so many students on. If any of them would like to be unmuted and share some of their firsthand experiences, you can also raise your hand and I will unmute you to talk.
I would encourage at least 1 or 2 of them to please do that.
I think we have one, so I'm going to go ahead and unmute. Give me just a second. You should be unmuted and available to talk. You might have to unmute on your end as well.
So Ms. Stearns is one of my students and she is actually across the hall. So if he needs to come over and use my microphone, she's welcome to do so.
Well, we might have to do that because everything for them is unmuted on my end. So I'm not sure why they're not able to speak.
We were using a projector in the other room that wouldn't let me unmute the projector, but I was just gonna say, I grew up in a neighboring town to Sarcoxy, and I grew up in a low-income town. And it was really nice to be able to give back in the community. And I really enjoyed doing the program. I thought it was a lot of fun.
And again,
Sorry. Wouldn't let me unmute the microphone. I was freaking out. I'm like, "Oh."
does anybody have any comments for her or questions?
Looks like we did have one question come in. It's asking, is Dr. Vick the follow-up dentist when further dental treatment is planned, or is there a referral to other dental offices? Is there a 6-month follow-up?
Yes, so that's a great question. So one, I guess answer that. I'm the supervising dentist here at MSSU hygiene program. I'm also faculty at Kansas City University. And we are opening a dental school. But to respond to your question, one, they will go back, they mean MSSU, will go back and do sealant checks. So there is follow-up as far as the placement of those sealants. And then also as far as treatment, working with the nurses, school nurses, is very, very helpful. Because they are instrumental in terms of finding, or at this time, finding places for these kids who are in need of treatment. Because through this process, of course, we were there to place sealants and do those screenings, but they did identify some children who had abscesses in this process, and we were able to get them referred. Once the school is open, we will be a resource as well. But currently, we're using other resources or dental providers in the community.
It will be a huge resource once KCU is open. You know, we give them information for community clinics and places that they can go. There are once, like Gary was talking about at the beginning of the webinar, is that the whole process is that we hope that we get some more local dentists to be Medicaid providers for these uninsured patients that need care. And so we're hoping that, you know, with the reimbursement rates going up, that we'll be able to get more access of care for these children to go to when they have emergency situations prior to KCU opening. We do, when we go back and we check these sealants that were retained, do our retention checks. We do those, like we're going in, we went into Wildwood in Sarcoxy in the fall. So this spring, our students are going back to go in and do retention checks. We had gone into in the fall to Jasper and Avila and done retention checks there. But we are then going again, actually just next Friday, we're going to Jasper School. And then we're going to see grades K through 6 at Jasper. And then at the end of the month, we're going in Avila to do screenings grades K through 6 at Avila. And then we will hopefully go back again in the fall to do retention checks there again. And so we're getting more access to care. We're seeing more students at the retention check time. If the sealant is not being retained, we will go ahead and replace the sealants and then also do additional sealants. Let's say that they, at the last check, they didn't have a tooth that was fully erupted and it didn't qualify for sealants, or they newly erupted a new tooth. If they have those teeth that are during the screening that need sealed, then we will go ahead and do that sealant that same day. So.
That's great. We did have another question. Dr. Vick, what is your position when the new dental school opens?
So yes, I'm the Director of Community-Based Education and Outreach. So what that means is, so KCU College of Dental Medicine, we have a really big community health and public health focus. So pretty early on, our students will start being in the community, and it'll start off with what's called Score One for Health, which is a free screening process that KCU has done for years. So my position again is the Director of Community-Based Education, and I'll be responsible or part of the team who will pretty much liaison between community projects and the school. That'll be for screenings, sealants, along with education.
We're also really blessed to have KCU serves as our supervising dentist here at our dental hygiene school at Missouri Southern. So we've been able to collaborate on these grants and some community programs, and we hope to, future do that in the future in this area.
We had a comment from one of your second year students that's participated in a sealant day, and that they're very glad to have the opportunity to provide sealants for the children, and surprised at how quickly the glass ionomer set. And said it made it easier for us to place a lot of sealants in a short amount of time.
Absolutely. I mean, you can see basically too with the protocol that Dr. Vick set up mostly too, that with it gives more the dental hygienist to work in our parameters and be able to make those decisions. And you can see the different, we were able to do 10 times more students and place that many more sealants in one day. So, that equipment's pretty heavy. It's hard to transport 6 mobile units, multiple visits. And so this keeps the cost down and being able to see more kids have more access to care and be able to place more sealants.
Another question that's come in, what do you feel is one of the main reasons for non-retention?
That's a big question.
Yeah, I mean, I would probably say, because even with glass ionomers, with the resin base, you need a higher degree of isolation. But even with glass ionomers, we can't be under saliva with those. So, you want that, you don't need that purely isolated dry surface with glass ionomers. But I mean, there is some opportunity for, I would say, a little moisture inhibition, if you will, there. But like I said, unlike with the resin sealants, the glass ionomer, like Mrs. said, affords opportunity to not have to worry about a completely dry environment. But we can't just be, what my old professor would say, underwater. So
yes,
yeah, I would say maybe just being that environment, overly moist environment, if you will.
yeah. And I do believe that the state is looking at that data to relate to other situations to kind of see that study.
But even with that, even when they're not visible, for example, on those retention checks, like you were saying, those particles are still there. And the evidence support that there is benefits that's still occurring as far as the fluoride and protection, even though we can't visibly see that nice sealant covering the entire tube. So it's in place, we are getting some benefits there, even when it's not clinically visible when we go back for those tests.
We also, a good note is we've also purchased UV lights. So there's research now that shows that you can use a UV black light, so to say, in the mouth. You can pick those up through Amazon or Walmart, and it's a low cost. But you might not be able to see it just visually with the eye, but these lights are showing that it's still present down into the pit and fissures. And so we are going to be utilizing that now when we go out onto our visits for retention effect, so that you can see that there's still some glass ionomer material present down in those pits and fissures, releasing the fluoride. Good question, though.
Along with that, what is your retention rate that you're seeing?
So this was a different thing. So there's Mrs. Powell can kind of tell you a little bit more about it, because she kind of started this in transition period,
Yes.
if you will.
Yes,
So this year, she'll be able to have the opportunity, once they have their first set of retention checks, to kind of provide that data.
yeah, I personally haven't, I've been at Avila and Jasper to look at retention and I sent that data in. But honestly, I can't say that I know that rate just because I haven't been in my position long enough to see the, on my end, the numbers. Does that make sense?
Yeah, I think that answers the question. More praise from another second-year student from Rachel. Found it to be educational and effective. Sorry for my little one. And lots of praise in the chat from the Office of Dental Health in regards to the work that your guys are doing, as well as from Diane Baumkamp, that it's hopeful and good that the hygiene students are getting to work within the community. So that hopefully down the road, they are more open to community roles.
Exactly.
There's still plenty of time for additional questions to add to the Q&A or the chat. While those final questions are coming in, just a reminder that today's webinar was recorded and will be on our website at a later time, and that you will be getting a CE certification survey at the end of the webinar that you'll need to complete for your continuing education credits. Ladies, no more questions have come in yet.
Well, I certainly believe, presenting this, and it's been a really neat opportunity working with MSSU, so this is really great.
Oh, it's been fabulous. It's fantastic that our students have this opportunity. So I want to thank the Department of Oral Health and Senior Services that we're able to go in and have the opportunity to have this grant to take them out into the community and provide this service for our community outreach. It's educational, but it's also, I think our students can say they really do enjoy working with these young kiddos and helping them.
And I also love that your students are getting a firsthand usage with teledentistry. I think right now in the changing landscape of things, that is invaluable.
It is, and who would have thought prior to COVID, but it's an absolutely fantastic way for these rural communities to get service.
Well, and that becomes all that more important because we know the dental workforce overall in Missouri is not as big as it should be. And so every efficiency you can interject in the system, the better off we are. And I see teledentistry as a big efficiency.
Absolutely.
Well, I was hoping we were going to have another student show up on camera, but I guess that's not going to happen.
They're probably still in their PJs or they don't have class today, so I just told them they could join wherever, so they didn't have to drive into the school.
Well, everyone who has attended will get a survey. Please complete the survey. And I believe I don't see any issues with tagging an email address to each of the attendees. So we want you to look out for that, and please complete it, even separate from CEs. We want to know what you think and any suggestions you have. The coalition is very much a learning organization. We do look at the survey results and take them very seriously. So we appreciate that.
Have you had much luck, Gary, with getting out into communities to discuss Medicaid and the reimbursement rates? And have you seen any interest in local dentists or?
There is definitely interest. We're really just in the beginning stages. So I'd say when word got out about the new rates, there was kind of a flurry of activity. I don't know, Jesse may be on here, but I don't believe we have like solid numbers of new dentists that have enrolled in Medicaid. We do know it's happening. Jessica Emmerich is on here, by the way. She's the with the coalition, and she's the dental Medicaid facilitator. So she's working directly with practices to help them, you know, go through the whole process of becoming a Medicaid provider. And, you know, that sounds like it would be simple. It's not. There's some complexity to that. And then yeah, there, you know, and I mean, you get a question about, is there a group number? Is it just an individual registration and all that has to be worked through. And then for the Medicaid managed care, then there's the credentialing process with each of the plans. And that has its own little twists and turns with it. So there's quite a bit to it. And then the whole issue with the claims and how claims are processed. It's a little different than what private practices are used to. It operates a little bit different than private insurance. So people have to learn all those rules. We're doing our dead level best to get the word out. There is as part of that project, which is, I should mention, is funded by the Missouri Foundation for Health. We're also developing a media campaign, a professional media campaign to get the word out to dentists. So we're doing a lot. You can hear a lot more about that at the conference if you can go. We're going to have a really excellent panel there to kind of talk about all the issues involved in that, including a person from MMAC, which people don't realize, but the claims process is kind of off on its own, and the provider enrollment is separate. That's not actually Mo Health Net Division. So we'll have both Mo Health Net Division and MMAC represented there, and I think people will get some good information and maybe dispel some of the mythologies. But overall, I think the biggest issue is that private practices are not used to dealing with Medicaid. They just have no experience with it at all. Most private practices, I should say. Obviously, there are some very noteworthy exceptions to that, but for the vast majority of private practices, they haven't used this. We think the rates now give them an important new piece of the market, if you want to look at it in kind of straight up business terms, that they really ultimately do not want to miss out on. I haven't looked at data lately, but the Health Policy Institute with the American Dental Association has put out material in the past that basically shows that for a lot of dental practices, the private insurance portion of the market is shrinking a bit. So capturing a public benefit like Medicaid, long term at least, is an important strategy for dental practices. And you know, people always think the FQHCs are going to pick it all up. They will never have enough capacity to meet the need out there. We need the private practice field out there working with these folks. And finally, this is a great opportunity to do that. I believe dental practitioners should not have to lose money to serve people in need. That shouldn't be the case. They should be paid well for that. And we're at a point where that's going to happen. So I don't know, or not Ashley, Jesse, if you have anything to add to that. I know you're muted right now, but we could pull you over. Probably she's not prepared to do a presentation today, but yeah, there's a lot to it. There's a lot of work to it. It's going to take time. There is interest to go back. Go ahead.
My question is probably for Jessica. So, does she just work with entities in private practice, or does she work with, like universities getting set up as well?
She is, you know, we have her in the attendee category, so she's muted, but she will work with anyone who wants to, you know, go through that process. So yes, I think she can assist you. She's not as technically proficient as some of the people at Mo Health Net Division. They have a woman named Amanda Ferendorf, a great partner.
Yeah, talked to her. Our issue isn't with Medicaid itself, it's the managed healthcare plans, but we're trying to figure out if how we could bill out at our dental clinic along with the grants, and whether we would need to do like a sliding scale or to make that.
Well, I am not an expert on this stuff, but Medicaid or Mo Health Net should be looked at as a particular payer. So they have rules about how they do their business, like all payers do, but they are not requiring you to do a sliding scale. That would be up to your business model there. They simply, if you are a Medicaid provider and you're enrolled properly, and in the case of managed care, credentialed properly, you'll invoice, which you also have to do properly, and they will pay you the going rate. The managed care plans have to pay no less than the fee for service rate that Medicaid has established. They can choose to pay more. They could pay for things they're not included. But you do have to, as a provider, you do have to learn a lot of new things like ME codes, because there's different categories of folks. There's really a limited benefit for the general adult population that are eligible for Medicaid. And so you have to be mindful of, well, what do they actually pay for and what do they not pay for? And I think at least on the fee for service side, if you submit a set of codes and there is a code in that list that is not covered, they will reject the entire claim. And they won't necessarily tell you about it in those exact terms. So you have to be up on that stuff on the front end. That's perfectly learnable. I mean, everybody can get ahead of that, but I think most private practices are used to doing the service and then billing all the codes that are applicable, and private insurance will typically, as I understand it, again, not an expert, they will typically pay for all of the eligible codes and just ignore the ones they don't cover. Mo Health Net does not do it that way. So that is a big difference and a big learning curve there that providers have to go through that process. It does take a little bit, I think, for providers that haven't done this before to learn it. It is doable. You have to put some time into it and stay on top of it, but it's certainly doable.
Is there anything else any questions or?
Jessie says she does not have anything to add right now. Apparently, I at least faked my way through it. That's really enough. Jessie worked with Mo Health Net for several years before she came here to the coalition, so she knows the stuff, and more importantly, she knows people. And you know, the problem oftentimes with state workers is they're all overworked, and you know, that's the case with Amanda. She's getting too much stuff thrown at her too often. She's a great resource, but I'm sure her email inbox is massive, and I think keeping up with it is a challenge. So Jesse's trying to fill in the gap there a little bit and help people, and more importantly, give them somebody to call and talk with about these things, to give them a clue about which direction to go. She won't be able to answer every question. We don't have her set up where she's operating like a state employee and you get right into their system and look at exactly what's going on, but she has a good understanding of how the system operates, and if nothing else, who exactly you need to
comment to us and tell her that or Jessica, thank you, and we'll probably be reaching out to you.
She would love that. Probably don't do it before the conference though, because we're all losing our minds between here and the end of next week.
I understand. Unfortunately, I won't be able to attend. I would love to, but we have already had scheduled our sealant placement at Jasper Schools that Friday, and I'd already had that on my schedule, so I
Sure.
will be going out with the grant and placing hopefully screening lots of kids and sealing lots of kids, so.
Sounds good. Yeah, we'll miss you, but I understand.
All right, well, thank you.
All right, Ashley probably has a few things to add, but I want to thank everyone for being here, and especially our two presenters. Really excellent project, outstanding information too. And I know we have a lot of dental professionals as well as students on here, and I know they all learned a lot. So
Thank you.
we appreciate the work you're doing and the great presentation you did today.
Thank you.
Ashley, what am I forgetting?
I was just going to say thank yous again and remind everyone that our conference is next Thursday and Friday, and registration is still open. And please complete your evaluation survey when you get the email later today.
All right.
All right, we'll close it down then. Thank you all very much. Have a great weekend, and get out, enjoy the nice weather when we get it.
Thank you.
All right.